Hello everyone and welcome to our module on high-yield EKGs. It can be very difficult to learn EKGs as a medical student, and one of the reasons is because there are so many potential findings. What I've shown on the screen are 9 EKGs that I think medical students should be familiar with. These are the type of EKGs that may come up on the Step 1 exam. They're also the type that you may be shown as a third-year student on rotations and you ought to be able to recognize. Now, some of these I talk about in other videos. For example, we have a video on atrial fibrillation and flutter. There's a video on ischemia and one on bundle branch blocks. So some of these things we'll touch upon in this video here, but not go into detail like I do in the other videos. But mostly what I'm going to do in this video is try to give you my approach for how to read EKGs, and this is especially helpful on your rotations when you're shown an EKG and asked to interpret it. When you're shown an ECG and you're trying to interpret it, the first thing I recommend you do is try to identify the P waves and ask yourself the question, are there P waves present in this ECG? If you see P waves present like shown here on this ECG, that's the first step to making an interpretation of all the major findings on the tracing. When you see P waves present on an ECG, most likely you're looking at sinus rhythm, and sinus P waves originate from the sinus node, obviously, and because they originate from this location in the right atrium, they will generate P waves that are upright in the inferior leads 2, 3, and F. So that's what's shown in this picture on the screen here. This is a patient with normal sinus rhythm, and there are P waves present, and they are upright, in other words, pointing in this direction in leads 2, 3, and AVF. Once you decide whether or not you think there are P waves on an ECG, the next thing you want to do is decide whether the heart rhythm is regular or irregular. And by this I mean whether the distance between QRS complexes, the RR interval, is regular or irregular. So at the top of the screen is a tracing from a patient with sinus rhythm, and you can see that the space between the QRS complexes is constant over the entire length of the tracing. At the bottom of the screen is an irregular rhythm. This is a patient with atrial fibrillation, and you can see that we have some QRS complexes that are far apart, like these two here, others that are very close together, like these two here, and then even others that are somewhere in the middle. So this is an irregularly irregular rhythm. The QRS complexes are not occurring at regular intervals, and that is the second step towards making a diagnosis of what you're looking at in an ECG. At the medical student level, it's very hard to remember all the different types of ECG rhythms, but a simple way to approach ECGs that you're shown is that if there are P waves present and the rhythm is regular, you're most likely looking at sinus rhythm. This is a very common rhythm and you should be able to recognize it, and once you see P waves in a regular rhythm, that is probably what you are looking at. There are other rare rhythms that can generate P waves and be regular, things like atrial tachycardia and atrial rhythms, but these are uncommon. Most likely a regular rhythm with P waves is sinus rhythm. If you see an absence of P waves and the rhythm is irregular, then most likely you're looking at atrial fibrillation. This is a very common rhythm, and atrial fibrillation along with sinus rhythm are two of the rhythms you ought to be able to identify. Atrial fibrillation generates an irregularly irregular rhythm with no P waves present. Now there are other things that cause no P waves in an irregular rhythm. These are things like atrial flutter with variable block, but this is much less common than AFib. Mostly if you see no P waves in irregular rhythm, you are probably looking at atrial fibrillation. And then just to round out the possibilities for steps 1 and 2 of my approach to reading ECGs, if you see P waves present but the rhythm is irregular, then you may be looking at one of these things I've listed here. So sinus rhythm with PACs may cause an irregular rhythm. I'll show you a picture of that later in this video. There's an uncommon rhythm called multifocal atrial tachycardia. This rhythm comes from the atria, not the sinus node. It will have P waves, but the rhythm will be irregular. And then finally, sinus rhythm with various forms of AV block can have an irregular rhythm, and I talk about this in another video. If you see no P waves and the rhythm is regular, then it can be some of these things I've written on the slide here. There may be hidden P waves, which can be retrograde P waves. These are seen in supraventricular tachycardias and ventricular tachycardias. These are relatively uncommon, but these are the possibilities when you see an absence of P waves in a regular rhythm. So step 1 when you look at an EKG is to decide whether the P waves are present. Step 2 is to decide whether or not you think the rhythm is regular. Step 3 is to then decide whether or not the QRS complex is wide or narrow. A normal or narrow QRS complex is less than 120 milliseconds on the ECG, or 3 small boxes. When you see a normal QRS complex, it means that the heart is using the His-Purkinje system normally and that there are no bundle branch blocks present. The only way you get a narrow QRS is if conduction goes through the AV node, through the bundle branches, and through the Purkinje fibers normally. If you see a wide QRS rhythm, then most likely you're looking at a bundle branch block, especially if it's an ECG in a stable patient. The other possibility for a wide QRS complex is that it's some type of ventricular rhythm like ventricular tachycardia. This will usually be in a patient who is very sick. In another video, I talk about bundle branch blocks, but just to quickly review here, this is a normal QRS complex at the top of the screen here. Even without measuring the number of boxes for the width of the QRS complex, you can see that it's very narrow from start to finish. In a right bundle branch block, the QRS complex becomes widened. Hopefully you can appreciate that this is a much wider QRS complex compared to the top. And similarly, in a left bundle branch block, the QRS also widens as shown here in this image. Moving on, the next step in interpretation of an ECG by my method is to check the intervals. So first check the PR interval. A normal PR interval is less than 210 milliseconds. 5 small boxes is 200 milliseconds, or 1 big box is 200 milliseconds. So basically, the PR interval should be about 5 small boxes or 1 big box in length, or shorter than that. If it's a prolonged PR interval, you may be looking at some form of AV block, which I talk about in another video. The PR interval also prolongs in the setting of high vagal tone or certain drugs that slow conduction in the AV node, and the PR interval can shorten in the setting of high sympathetic tone. After the PR interval, you want to look at the QT interval. A normal QT interval is less than half of the RR interval. That's the rule of thumb you can use for measuring this, and I talk about this in more detail in the video on ECG basics. The QT interval becomes prolonged with hypocalcemia. These patients will have tetany and numbness and spasms. The QT interval also becomes prolonged by antiarrhythmic drugs. And then the QT interval can be very short in patients with hypercalcemia. These patients usually have confusion and constipation. They can also be volume depleted. And then the final step in my method for analyzing ECGs is to look at the ST segments. You want to look for things that may represent ischemia. So for example, T waves can be inverted in ischemia as shown in this picture here, and I talk about this in the video on ischemic basics. There are also other T wave abnormalities. T waves can be peaked in early ischemia and in hyperkalemia. There can also be flattened T waves with U waves present in hypokalemia. And then finally, ST depression and ST elevation are both signs of ischemia. There's some ST depression in this ECG on the screen here. This is the beginning of the ST segment. This is where it ends, and you can see that it's depressed. At the bottom of the screen is an example of ST elevation. These are both signs of ischemia that I discuss in more detail in the ischemia basics video. So now let's try to use this method to analyze a couple ECGs. So I want you to imagine that you're handed this ECG on rounds and your attending asks you to interpret it. How are you going to do that? Well, let's talk about the steps and go through them one at a time. So the first step is to decide whether or not there are P waves present. And if you look at the rhythm strip at the bottom for lead 2, it's very easy to identify the P waves. They're all over the place here in lead 2. You can also find them easily in lead V6 and V5. In some leads, they're harder to see. For example, they're harder to see in V2, but if they're present in all the other leads, then you can know that there are P waves present. So this ECG has P waves present. Step 2 is to decide whether the rhythm is regular, and you can see that the distance between QRS complexes is constant or regular. Step 3 is then to decide whether or not the QRS complex is wide or narrow, and hopefully you can recognize that this is a very narrow QRS complex of about 2 small boxes. So we do not have a bundle branch block present or any type of cause of a widened QRS complex. So what we're looking at overall here is a rhythm that is regular with P waves present with a normal QRS complex, and that's most likely going to be normal sinus rhythm. That's what this ECG shows. Now we want to be complete and not miss anything, so let's move on to step 4 and check the intervals. The PR interval starts about here and ends about here. It's less than 1 big box in length, and that is normal, so we have a normal PR interval. And then the QT interval begins at one of the QRS complexes and ends at the end of the T wave, and you can see that the QT interval here is less than half the RR interval, so we do not have a prolonged QT interval. And then finally, we want to look at the T waves. The T waves here are upright. They are not elevated or depressed, so we have no evidence of ischemia. So this is basically a normal ECG, and you're often shown these on rounds and asked to interpret them, so you should be able to recognize normal sinus rhythm. Now let's go through the method again using this ECG. So step 1 is to decide whether or not there are P waves present, and it's very easy to see P waves here in lead 2. You can also see them in lead 3. You can also find them in lead V3 and V2. They're all over the place, so there are P waves present on this ECG. Step 2 is to look at the distance between the QRS complexes, and you can see that it's regular. There is a constant distance between QRS complexes. So we're dealing with a regular rhythm with P waves present, so we already know that this is most likely going to be sinus rhythm. In addition, you can look and the P waves are upright in leads 2, 3, and AVF as you expect for sinus P waves, so most likely sinus rhythm is present on this ECG. Step 3 is then to look at the QRS complexes, and if you look at lead V1 here, you can see that this is a wide QRS complex. It's about 4 boxes in width, and that means that there is some problem causing a wide QRS complex. And like I told you earlier, when you're dealing with an ECG that shows a wide QRS complex, most likely you're looking at some type of bundle branch block. And in another video, I talk about how to identify a right bundle branch block. It's always pointing upward in lead V1, and that's what you've got here, is sinus rhythm with a right bundle branch block. Now, for completeness sake, let's go through the rest of the steps to make sure we're not missing anything. So if we check the PR interval, it starts here and ends about here. It's less than 1 big box in width, so we have a normal PR interval. We can then look at the QT interval, which starts here and ends here. You can see that it's less than half the distance between the QRS complex or half the RR interval, and therefore we have a normal QT interval. So we do not have prolongation of the PR interval or the QT interval. And then finally, we look at the T waves and the ST segments. Now, you can see that T waves are inverted here in lead V1. And you may not know this, but that's a normal finding in right bundle branch block. It does not mean that there is ischemia, but there are ST and T wave abnormalities on the CCG. They are all consistent with right bundle branch block, which is not something you're likely to know at the medical student level. But you should at least be able to identify that this ECG shows sinus rhythm with a right bundle branch block. Now let's take a look at this tracing, and we'll start with step 1 and look for P waves. And it's easy to find P waves here in lead 2 down along the bottom of the ECG. You can also see them up here in lead V1. I can also find them here in lead V3. They're all over the place, so we have P waves present. Next step is to decide whether the rhythm is regular or irregular, and hopefully you can identify that this is a regular interval with no variation in the RR intervals. Once we've done that, we look at the QRS complex, and hopefully you can see that this is a wide QRS complex. It's almost 1 big box, or 200 milliseconds in width, so this is a very wide QRS complex. And in this case, we have a wide QRS complex, which, as I told you before, is most likely a bundle branch block, and in V1 it's pointing down. So in another video, I talk about left bundle branch blocks, but they always have a QRS complex that is wide and pointing downward in V1. So what we're looking at on this ECG is sinus rhythm with a left bundle branch block. Now for completeness, let's go through the rest of the steps. So the PR interval is from here to here. It is normal in width. The QT interval begins here and ends here. That is not prolonged, so we have a normal QT interval. And then the last step is to look at the ST segments, and there are a lot of ST abnormalities here. The T wave's inverted here in leads 1 and AVL. There is ST segment elevation here in lead V2. All of these findings are normal components of a left bundle branch block. You don't need to know this at the med student level, but it's very difficult to diagnose ischemia in the setting of a left bundle branch block because many of the normal findings that go with the left bundle are also findings of ischemia. So this patient actually does not have evidence of ischemia. This patient just has a left bundle branch block. You don't need to know that at the med student level, but you should be able to identify that this ECG shows sinus rhythm with a left bundle branch block. Now let's go through this ECG here. So step 1 is to decide whether or not there are P waves present, and hopefully you can see that there are no P waves on this ECG. There are some bumps like these up here in lead 1 that you might think are P waves, but they don't occur regularly before each QRS complex. And if you look down here, for example, at lead V5, there really is just this wavy baseline but no P waves. So there are no P waves present on this ECG. Step 2 is to decide whether or not the rhythm is regular or irregular, and hopefully you can recognize that some of these QRS complexes are close together, for example these two here, others are further apart like these two here, and others are somewhere in the middle like these two here. So what we have is an irregular rhythm with an absence of P waves, and like I told you before, when you see that, most likely you're looking at atrial fibrillation, and that's what this ECG shows, atrial fibrillation. Now I'll just go through a couple of ECGs that are basically pattern recognition. So if you look at this ECG here, the baseline has this so-called sawtooth pattern, and when you see that, you should think of atrial flutter. Atrial flutter has this sawtooth pattern present. You should see the sawtooth pattern in every single lead. It shouldn't be present in just one lead. If that's the case, you may be looking at something else. Note also that the QRS complexes are irregular here. These two are far apart and these two are close together. Atrial flutter can generate a regular or irregular rhythm depending on the conduction from the atria to the ventricles. Here's a very abnormal ECG. This is one that you just basically have to recognize when you see it. These QRS complexes are very wide and they are very fast. They are so close together, they are occurring at about 300 beats a minute. And this is what you see in ventricular tachycardia. Ventricular tachycardia is a wide, complex tachycardic rhythm. I've zoomed in on one of the leads so I can show you these little bumps that you can see here. You can also see them here, and you can see them here. These are the P waves. So the ventricle in ventricular tachycardia is depolarizing at a very rapid rate, generating the wide complex waves. At the same time, the SA node is depolarizing, and it occasionally generates a little P wave, which will be a little bump that you will see on one of the wide complexes coming from the ventricular rhythm. Torsade de Pointes is a special form of ventricular tachycardia where the QRS complexes form this undulating sinusoidal pattern like shown on the screen here. This is just pattern recognition. You just have to have seen this to recognize it. The way you get this arrhythmia is if you have a PVC occur during the QT interval. So patients with a prolonged QT interval are at the greatest risk. There are a number of antiarrhythmic drugs that prolong the QT interval, and they put patients at risk for torsades. There is a congenital long QT syndrome, and patients who have this disorder are at risk for torsades. And then finally, some antibiotics occasionally prolong the QT interval in certain patients. The drugs that classically do this are erythromycin and the quinolones. You can also develop torsades unrelated to the QT interval in certain electrolyte disorders. Hypokalemia and hypomagnesemia are famous for causing torsades, and in fact, giving magnesium is one of the ways you can treat this arrhythmia. What's interesting is you may know that hypocalcemia can prolong the QT interval, but it turns out that torsades is fairly rare in hypocalcemia. The reasons for this are not well understood, but nevertheless, hypocalcemia can potentially cause this arrhythmia, although the more common electrolyte disorders are hypokalemia and hypomagnesemia. A PVC is a premature ventricular contraction. It is a depolarization that originates in the ventricles and causes the myocardium to depolarize outside of the control of the SA node. So if you look at this rhythm strip at the top of the screen, we've got a sinus P wave followed by a QRS complex and a T wave, another sinus P wave and a QRS complex and a T wave, another one, and then we have this early, wide, aberrant looking beat. That is a PVC. This electrical activity originates in the ventricle. It doesn't use the AV node and the bundle branches. That's why it doesn't generate a normal looking QRS complex. Instead, it generates a wide, bizarre complex, and that's a PVC. It's premature in that it comes in earlier than you would expect for the next QRS complex. The next QRS complex after these first three should occur somewhere about here, but instead we get an early complex that's a PVC. And at the bottom of the screen is another early complex right here, but it has a narrow QRS, normal looking QRS complex. That is a PAC. It's an aberrant electrical impulse that is generated by the atria, and for that reason it uses the AV node and the bundle branches, and it has a normal looking QRS complex, but it's still early, and therefore it's a premature atrial contraction. And that concludes our video on high yield EKGs.